the immunosenescence is really a bad term because we try to introduce a sort of bias by thinking that everything which goes on in the immune system is bad for the elderly individual. So, and recently perhaps we think that the changes in the immune system with aging are not just senescence, but can be a sort of adaptation. So these changes, of course, are decreasing, increasing, and there are so many cell types, so many functions, so many things which goes on that we cannot really see a trend for everything that's going on. And since we have the new immunotherapy that we can see in cancer and in other part of the medicine, we knew that it can be exactly the same significance in elderly. So it questioned also whether the immunosenescence, the so-called immunosenescence, is really a sort of senescence or really something that can adapt it during the life of the individual, during all the immunological challenge that they could undergo. And this means that nevertheless, they can respond to an immunotherapy. So that's what we are trying to put forward, that in fact the age of the subject is not a limit for doing immunotherapy. This is somehow quite detrimental for elderly because in many settings like vaccination, treatments, immunotherapy, cancer treatments, rheumatoid disease treatments, many elderly are just excluded from the trials and also from the treatment on an everyday basis because they are just old. So, and they are excluded because they think that as their immune system is not so good as in young people, so they cannot answer to the treatment sufficiently, so it's useless to do these treatments in these patients. I think it has a very great future. I think if we understand much better in a different way our immune system with aging, and we can really extract what is beneficial for elderly, either in the immune changes or what we call the inflammaging, so the inflammatory setting with aging, we can really use the immunotherapy. Of course, immunotherapy will never be just one shot. It will be a combined immunotherapy. So we should really, when we understand how the immune cells can really combat the cancer and may help for the immunosurveillance for the cancer cells. And I think then we can use this therapy much efficiently, either in elderly or in young people, whatever is the age, because I think it's not the age which is really the determinant, but this is the nature of the tumor, the nature of the immune response, the nature of the inflammatory status of the person, which are the most important when we decide whether to use or not the immunotherapy. But I think the next years will be very beneficial for elderly by using several types, because we use mainly the inhibitory checkpoint treatment for the PD-1, for the CTLA-4, but there are many other things that we can use against the anti-inflammatory cytokines like TGF-beta, IL-10, or even for increasing the co-stimulatory receptor activities. So there are many other targets that can be used in the immunotherapy, not only the PD-1 or the CTLA-4, which are the most known actually, but with the research we can really increase the diversity of the immunotherapy.